In previous video, I discussed about thin endometrium. What are the routine things we do about increasing the thin endometrium in an infertility practice? Endometrial profile and endometrial preparation, endometrial thickness, endometrial vascularity is a very important part of an embryo implantation in both patients who are trying normally, who are going for IUI, and for IVF patients. Today's video we will discuss about one very important molecule which increases the endometrial thickness, which is called as G-CSF, new kind or granulocyte colonic stimulating factor. What is this G-CSF? What is the mechanism of this G-CSF for increasing endometrial thickness? How do we use this endometrial G-CSF for increasing the endometrial thickness? In what dose this G-CSF has to be used? What are the results of this G-CSF? We will discuss all in today's videos. Good morning, good afternoon, good night, wherever you are. I am Dr. Rajat. I am an infertility specialist and a gynecologist practicing at Matrut Hospital, and we started watching our YouTube channel, The Fertility Gynecologist. I mentioned in my previous video, an optimal endometrial thickness for a good implantation is about minimum 7.5 to 8 millimeter. Sometimes, in spite of doing everything, the endometrium does not cross more than 7 millimeter, or it is even less than 6 millimeter. And those times are especially tough when we are going in for an IVF cycle, when we have tried ecospirin, we have tried sildenafil citrate, we have tried L-arginine, we have tried vitamin E, we have tried estradiol valerate or estradiol hemihydrate. In spite of that, if the endometrium does not increase, what to do? In last few years, or for that matter in last 15 to 20 years, a good molecule has come, which we called as granulocyte colony stimulating factors. Implantation usually does not occur because either the embryo is not good or the endometrium is not good, or even if both are good, there is an endometrial embryonic asynchrony. This G-CSF, it not only increases the vascularity of endometrium, it improves the immune system of endometrium, it improves the thickness of endometrium, and thereby it improves the implantation rates also, especially in an IVF cycle. So what is this G-CSF? G-CSF is a glycoprotein. It is mainly synthesized by the bone marrow cells, stem cells. It is also synthesized by the endometrium. It is also synthesized by the granulosa cells. And there are many other cells in which the G-CSF receptors are found. The quantification of G-CSF has been found in last many years to give us a indicator of oocyte quality. In cycles, the level of G-CSF increases till the ovulation, and thereby it is maintained. So the levels of colony stimulating factor in follicular fluid are taken as a measure of oocyte competence. We normally do not measure granulocyte colony stimulating factors level in our routine practice. It is basically a hematopoietic protein which is produced, like I mentioned, by bone marrow cells, stem cells, endometrial cells, macrophages. And it basically increases the production, mobilization, migration and differentiation of different stem cells. It improves pregnancy by increasing the amount of helper 2 cells, macrophages, and it modifies the TREG activity. That is very, very important. It can be used in two ways. It is a simple pre-filled injection which is available as 300 microgram per ml. It can be used subcutaneously also. It can be used intrauterine also. Intrauterine infusion of G-CSF has been found to increase endometrial thickness, while subcutaneous or a systemic administration of G-CSF has been found to overall increase the pregnancy rates in IVF, and it also increases the endometrial thickness. It is supposed, how does G-CSF increase the endometrial thickness? It basically stimulates the endometrial stem cells. It also mobilizes the bone marrow stem cells, which helps in the growth and differentiation of endometrium. Since it is produced by granulosa cells, it enhances the follicular growth and steroidogenesis. Because it is also produced by endometrium, it improves the luteal phase and thereby improves the decellulization. And it is also produced from the placenta, and hence it favors the sustenance of pregnancy. So these three mechanisms, because G-CSF is produced by granulosa cells, the level of G-CSF is an indicator of an oocyte competence. Because it is produced by endometrial cells, it increases the endometrium and it favors the implantation. And because it is produced by placenta, it favors the sustenance of pregnancy. It mainly recruits the dendritic cells. It activates the TREG cells. it promotes the helper 2 cytokines, and it stimulates the pro-angiogenesis, and these are the mechanisms by which it increases the endometrial thickness. Now the most important question, how it should be used. Like I mentioned, Norbert Gleichert and Barash et al., they basically use it in an intrauterine manner. Just like we do an IUI, we connect the 1 ml pre-filled syringe with an IUI catheter, put it into the uterus. An IUI catheter is put it into the uterus, and a slow intrauterine infusion of GSF is done over 5 to 7 minutes. Patient is asked to lie down for about 5 to 10 minutes, and it has been shown that intrauterine infusion of G-CSF, it increases the endometrial thickness by about 1.7 to 2 millimeter within 48 to 72 hours. If within 72 hours after intrauterine infusion of G-CSF the endometrial thickness does not increase, we can repeat once again, but in most of the cases it is not needed. Subcutaneous 300 microgram per ml injection of subcutaneous G-CSF or Nucoin can also be given to increase the endometrial thickness, and various recent reports are coming which confirm that whether you give by intrauterine or you give by subcutaneous, the overall effect on endometrial thickness is roughly the same. Because intrauterine infusion of G-CSF requires vaginal examination, requires a IUI catheter, and it is slightly uncomfortable, I personally prefer to give it subcutaneously. So the protocol of giving a G-CSF is, especially in a frozen embryo transfer cycle, when from day 2, day 3 we start the estradiol valerate or estradiol hemihydrate, we do a transvaginal ultrasound at about 10th or 11th or 12th day to look for the endometrium. If endometrium at that point of time is 999 but it is less than 7 millimeter, then we give intrauterine slow infusion of G-CSF, wait for 72 hours and again do transvaginal ultrasonography while still continuing with the estradiol valerate. What I personally do if patient is undergoing an frozen embryo transfer cycle, along with estradiol valerate, I start either sildenafil citrate or L-arginine or both, depending upon the previous experiences. If there is a persistently recurrent thin endometrium, then I start a cocktail of ecosprin 150 mg, sildenafil citrate 50 mg per vaginal, L-arginine 3 gram 3 to 4 times a day, in sachet form. L-arginine is a nitric oxide donor, sildenafil citrate would act as a vasodilator. They both would increase the spiral artery blood flow, thereby the endometrial blood flow would improve. I would also start, if there is a previous recurrent history of IVF failure, I would also start pentoxifylline and vitamin E, pentoxifylline 400 mg 3 times a day, or vitamin E 400 mg 2 or 3 times a day, and then we will go to day 10 or day 11 and we see how much endometrium is there. Apart from thickness, pattern is also very, very important. Triple line or a 5-line endometrium has to be seen, which is very, very important. If triple line endometrium is there, that would suggest to me that the vascularity overall is good. Even if the thickness is relatively less but pattern is good, then the chances of implantation are good. Along with the pattern and thickness, we put a power Doppler on and we see how much vascularity is there, where the blood supply is there in zone 2, zone 3. G-CSF has been shown to improve the vascularity to zone 2, zone 3 also, and thereby improving the chances of implantation. They compared an intrauterine and a subcutaneous route. The change in endometrial thickness in intrauterine was about 1.76 plus minus 0.6 millimeter, and in subcutaneous it was 1.84 plus minus 0.6 millimeter. The endometrial blood flow in an intrauterine route increased by about 61.2%, and in subcutaneous route it increased by 71.4%. And the clinical pregnancy rate was higher in the subcutaneous rate. It was 47% compared to the 40% in intrauterine route. So if I compare both intrauterine and subcutaneous, the cost wise also subcutaneous is better. It is hardly a 2-second injection. Patient can directly put. Patient does not need to come to the clinic to get an intrauterine infusion do, while an intrauterine infusion would require a proper position of a lithotomy position. Intrauterine catheter, IUI catheter would be required. She would be required to lie down for about 10 to 12 minutes, and the overall results are same. I also have tried G-CSF in my routine patients, those patients who have undergone multiple curetages, those patients who have history of tuberculosis, and in whom we are trying normal ovulation induction with either timed intercourse or ovulation induction with IUI in spite of giving HMG injection, in spite of giving letrozole, in spite of not giving clomiphene citrate, and in spite of doing all these things which I mentioned before, L-arginine, sildenafil citrate, the endometrium thickness does not increase. Then what I do is, along with the SCG injection at the time of trigger, either on that day or the day after, I give subcutaneous 150 microgram GCSF, and remaining 150, that is 0.5 ml, I do intrauterine. Now bear in mind, from an ovulation to implantation, there we still have got 7 days. So if the endometrium is not 7 millimeter on the day of ovulation trigger, it is fine. If it is 3-line endometrium, there is good vascularity. Along with trigger, give 150 microgram GCSF, and at that point of time, you can also give intrauterine. Intrauterine would have slight effect of just about brushing the endometrium. So it would also act in just kind of stimulating the endometrium for a mild endometrial scratching effect. It would also increase the endometrium, and we'll still have 3, 4, 5 days before the embryo forms and comes to the endometrium. So G-CSF is a good drug. It can be tried. It is not a very expensive drug, hardly costing about 500 to 700 rupees. When you are doing an HMG cycle, doing an IUI, an injection of G-CSF would not make much of a difference as far as cost is concerned. So in conclusion, especially in patients of implantation failure in previous IVF, it is better to give subcutaneous G-CSF just before the embryo transfer. When doing the routine patients of IVF, the routine use of G-CSF has got no effect. When compared to intrauterine and subcutaneous, intrauterine use of G-CSF only increases the endometrial thickness, while subcutaneous use of G-CSF not only increases the endometrial thickness, but it also increases the overall pregnancy rate. And after giving G-CSF before embryo transfer, the pregnancy rate becomes to about 40 to 50%. I personally use GSF in most of the recurrent implantation failure patients. G-CSF can also be used in patients in whom there is a persistent unruptured follicle, that we in our language call as luteinized unruptured follicle. Sometimes follicle does not rupture in spite of giving SCG 5000, in spite of giving SCG 10,000, in spite of giving SCG plus oxytocin. In those cases, G-CSF may be tried. I'll make another video of luteinized unruptured follicle and the role of G-CSF in it. One request to all the viewers, please like the video, please share the video, please comment and help us grow further. Thank you. Bye-bye.